Hi everyone, I'm Dr. Kelly Lipp. I am so sorry that I can't give this Zoom lecture live, but hopefully having this pre-recorded will still get you some good dental info and also be somewhat interesting. So the title of this lecture is Pediatric Dentistry in a Nutshell. I work with 3 other doctors on the corner of Peacehaven and Robin Hood. Our office is called Spangler, Rohlfing, and Lambert Pediatric Dentistry. You should definitely come and check us out if you ever have a moment. So our objectives for today, we have quite a few, is to understand the development, diagnosis, and treatment of cavities, review the guidelines for SBE dental prophylaxis, review the management of pediatric dental trauma, become familiar with the recommendations for non-nutritive sucking, review tooth loss and space management, and then I'm going to go over some clinical pearls. So those are simple ways to implement oral health guidelines in your pediatric practice. So starting with the first objective of understand the development, diagnosis, and treatment of dental caries. For development, we need 4 things. You need a tooth, obviously. You also need bacteria. We previously thought that just S mutants was the sole cause of dental caries, but now we know it's a complex microbiome, so a whole bunch of different bacteria. The key players are bacteria that are acidogenic or acid producing and acid uric acid loving. You also need a fermentable carbohydrate. Any type of fermentable carbohydrate will work. Key players include milks, juices, processed carbs, so the goldfish that every 2-year-old is obsessed with. And then other things for pediatricians to think about are liquid meds, gummy and chewable vitamins, and meal replacement supplements. So you probably are going to recommend a lot of these things to children, and just letting parents know that these are things that can cause cavities. So for the liquid meds, if it's possible to not give them before bed or brush them, or if they have to be given before bed, make sure that the child brushes afterwards. For gummy and chewable vitamins, recommend taking them in the morning. And for meal replacement supplements like the Ensure and Pediasure, just letting parents know that it's filled with sugar and very thick, so ideally drinking water or even wiping the teeth off afterwards. Lastly, you need time. It takes about 2 years for a cavity to break through the outer layer of the enamel of the tooth. So before those 2 years, so while the process is starting but not all the way through, we can treat this preventatively. So we can do this with fluoride, with diet modification, and with oral hygiene. After the enamel breakthrough, you need to do a surgical intervention. What is surgical? For dentists, that would be a filling. If we eliminate, or if we have all 4 of those things, we're gonna get dental caries. And if we eliminate any one of these components, we won't get dental cavities. So if we have no teeth, obviously we won't get cavities. If there's no bacteria, aka we're doing a really good thorough debridement through good oral hygiene, we won't get cavities. If we eliminate the fermentable carbohydrates, so some kids with very stringent ketogenic diets or G-tube fed children, they're not gonna get cavities. And if we eliminate the time component, so if the caries risk factors are only very transient, then we also won't get cavities. For diagnosis of cavities, there's 2 ways, radiographic and visual. For radiographic, we usually use an x-ray called a Bitewing X-ray. So this is an x-ray of all baby teeth. In this x-ray, we can see the baby teeth. We can see the pulp or the nerve, the innermost layer. We can see the dentin or the middle layer. And we can see the outer protective enamel or the outer layer. In this x-ray, we can see some cavities. They show up as darker shadows in the outer layer of the enamel of the teeth, as you can see right there. For visual diagnoses, here's a picture of a cavity-free smile. Here's something called white spot lesions. So right along the gum line, you can see where the tooth becomes more opaque and white. That's a sign of demineralization or start of cavity process. Here's a picture of cavities, and here's a picture of large cavities that have broken down tooth structure with an abscess where you can see that bubble in the gum. For some other pictures of cavities, just so you can familiarize yourselves with what they look like, you can see different pictures here. So they come in all sorts of shapes, sizes, colors. Brown, blacks, yellows, oranges are all common, sometimes even green. So those are all pictures of cavities. So now, since we're talking about cavities, when should we send kiddos that you see with dental cavities to the emergency department? And when I'm talking about the emergency department is a lot of the patients that you see that are coming in for dental pain don't have an established dentist. So if they have pain, should we send them to the emergency room? No. Why are cavities painful? So since cavities are a bacterial-driven process, it's a bacterial infection in the tooth. So initially, in the stages of cavities development, when the bacteria is just very superficial and is very far from the nerve, the cavity is not painful at all. And how you would fix that is just with a simple filling. When the bacteria gets closer to the nerve, you start to have pain, and this type of pain is to hot, cold, and sweets due to the stimulation of the dental nerve. And you can also fix this with a filling, just a larger one than if you catch it when it's earlier. Once the bacteria gets into the nerve, that's when pain becomes spontaneous or nocturnal. So that's when parents start remarking that their kid was up all night with dental pain, or when kids say that it's just random, like when they're lying down or watching TV. That's when you know that the bacteria is all the way into the nerve. And the way you fix that is with a root canal, which is a process where the root, not the root, is a process where the nerve of the tooth is removed and disinfected and filled with a inert material to stop the infection and to rid the patient of pain. Lastly, once the infection, if it goes untreated, gets into the nerve, it can travel out the bottom of the nerve and create something called a periapical infection, basically an infection in the bone immediately below the tooth. This causes pain to biting due to the pressure, and once it gets really large, the pain becomes constant. You can fix this with either a root canal or with actually removing the tooth. And I'm going to talk a little bit more about whether you should give antibiotics in this situation. So when parents or patients tell you their dental history and they talk about pain that was present and then when it went away, that can also help you stage where it was. So initially, cavities aren't painful. Then they become painful as the cavity gets closer to the nerve and then into the nerve. And then there's this magical time where the nerve is dead or necrotic and the infection hasn't gone outside the apices of the tooth and into the bone. And that's where you don't feel pain anymore. Then you'll start feeling pain again once that infection builds up and puts pressure in the bone. And then sometimes the pain will go away again if a sinus tract or drainage happens, because a dental infection is not painful once the tooth is necrotic and if the infection is draining. And as you can see here, there's a good picture of a nice little abscess. So should we give antibiotics for dental pain? So a lot of patients are going to come to you, they're going to have dental issues, they're going to have dental pain, they want you to do something for them. Can we give them an antibiotic to make them better? Unfortunately, the answer to this situation for almost all the cases is no. So antibiotics do not get into the tooth very well. So they're not helpful when the bacteria is only in the tooth. So how will you know if you should give your patient an antibiotic? Based on their symptoms. So if they say that they're asymptomatic, or if the pain is only with hot and cold and sweets, or if the pain is spontaneous. Those are all signs that the infection is still solely inside of the tooth and not in the bone, and your antibiotics aren't going to really get you anywhere. Antibiotics poorly penetrate the bone. So we know that from our orthopedic friends and how much they dread total joint infections. We know that antibiotics don't get in the bone very well, especially the bone around teeth. So we still say if the symptoms are that they're having biting pain, antibiotics still aren't indicated. The best way to treat this is to treat the tooth, and the only possible exception is if the patient doesn't have a dental home. So if you think that it's going to take them a very long time to get into a dentist, you can prophylactically give them an antibiotic to hopefully prevent other complications. But some may argue that that will remove pain and then also remove the motivation to actually go to the dentist. So the full exception or definite exception to give someone an antibiotic is if the infection is systemic. So if you see facial swelling or fever. So why can some dental infections become systemic? So it's basically just determined by the path of least resistance. So once you get an abscess or infection out the bottom of the tooth, the infection can travel in two directions. So it can either go out the alveolar plate and create a sinus tract, like you can see here. And for that, since it's draining, no antibiotics are indicated. Or if the path of least resistance is further into the body, so into the facial planes, then it will create a systemic infection. Antibiotics are indicated. A lot of times you need to do IV antibiotics. And a lot of times these kiddos are going to be admitted and need to be monitored. The one thing I always ask is remember that the source is the tooth. So even if they're admitted and they get IV augmented and that helps with the facial swelling, the source of the infection, the tooth is still there. They still need to see a dentist to get it out. I think this is super interesting because just which way the bacterial infection travels is a determinant of if it becomes a major infection or just a simple draining sinus tract. And back in the day before antibiotics and modern dentistry, it was the deciding factor of who lived and who died if they had cavities, which is scary. So should we send them to the emergency room if they have a draining abscess? And we've covered this, but no. A draining abscess is typically not painful. Antibiotics are not indicated because the infection is draining. What about for fever? Yes, we do want to send to the ED for fever because it indicates systemic involvement and antibiotics are needed. And you should consider hospital admission for these kiddos, not just oral antibiotics, if their fever is over 101.4, if they're lethargic, if the infection has progressed or the fever has progressed rapidly, if the child has special healthcare needs, or if the child is immunocompromised. What about for facial swelling? So for that, we also want to consider sending to the ED because it also indicates systemic involvement and antibiotics are needed. You should consider hospital admission if there's secondary space involvement. So primary space is all the space just immediately surrounding the teeth. So if it's just in the primary space, you see like a gumball size swelling right here, that's considered primary space. What we don't want is it going to secondary spaces. So that would be if you see swelling periorbital or down here by the chin. We also would consider admission if there's trismus or there's limited opening. That indicates that the mesenteric space has been invaded, or if we're worried about impending airway compromise, such as difficulty breathing, difficulty swallowing. So AKA, if we see swelling near the airway, near the eye, preventing jaw opening, or we're just concerned about the patient being able to breathe, we should definitely admit them. This is the part where I leave for questions for dental cavities, but I ask that you guys just email me if you have any questions. This is my email, kellymlipp@gmail.com. It's gonna come up a couple of times in this presentation. So our second objective, review guidelines for dental SBE prophylaxis. Last year, everyone seemed very comfortable with this, so hopefully you guys are too. So you're called by a dentist wanting to know if they need to do SBE prophylaxis for 2 patients. One patient is 4 and has mild aortic stenosis and trivial aortic insufficiency. The other is 9 and has ventricular septal defect with a gradient of 90 millimeters mercury determined with an EKG. So of the following, the current AHA guidelines for SBE prophylaxis is that they both need SBE prophylaxis. They both need SBE prophylaxis, but only for major dental work. Neither of them need SBE prophylaxis. The 4-year-old with the mild aortic stenosis needs prophylaxis, whereas the 9-year-old with a ventricular septal defect does not, or the reverse. So the 9-year-old needs it, but the 4-year-old does not. Take a second to think about your answer, and the answer is C. Neither are going to need prophylaxis for any dental work. Why is that? So the indications for prophylaxis have changed to include fewer diagnoses. So we are more stingy with who we give antibiotics to, which is a good thing. Bacteremia occurs frequently with normal daily activities, so that includes toothbrushing. So if we're not giving kiddos antibiotics every time they brush their teeth, then the argument is, why do they need it for other routine dental work in a dental office? Improved oral hygiene is more important than the use of antibiotics, And neither child in this situation requires the antibiotic because they don't have any cyanotic congenital heart disease. So just a reminder, you guys probably know this way better than I do, but the cyanotic ones are tetralogy of Fallot, transposition of the great arteries, pulmonary atresia, etc. And then non-cyanotic ones, which is this situation, was the ASD, VSD, PDA, etc. Also, it's not indicated here because they don't have any cardiac procedures involving a prosthetic valve or a prosthetic patch. So indications for dental prophylaxis include patients with infective endocarditis risk. So those are people with prosthetic valves. They've had infective endocarditis in the past. They have an unrepaired cyanotic congenital heart defect that we just went over. Or they have a repaired cyanotic congenital heart defect within the past 6 months. Or if they have had a heart transplant and the heart transplant has valvulopathia. Another situation to consider dental SPE prophylaxis are patients who are immunocompromised. The guidelines here are less straightforward. It's more based on a judgment. So you can consider for patients with things like HIV, chemo, any sort of organ transplantation, head and neck radiation, chronic steroid use, diabetes, or bisphosphonate therapy are good examples. So if you decide a patient does need antibiotic prophylaxis, what dental procedures require coverage? And the answer is most procedures. So it's by definition anything that could cause bleeding or manipulation of the gums. So that would include injections, cleanings, deep cleanings, and scaling and root planing. Scaling and root planing is just another fancy word for a deep cleaning. Root canals, extractions, and most fillings, because during most fillings we're gonna manipulate the gums and we're gonna give them local anesthesia. Procedures that don't need SPE prophylaxis would be exams, x-rays, and orthodontic appliance adjustment, which is helpful to know because when you have little immunocompromised patients that need to have their antibiotic coverage for dentistry, they're gonna need it for their ortho only when their brackets are placed and when they're removed. Then when they go to the orthodontist every 6 weeks for the next 2 years, you don't have to keep giving them the antibiotic because minor things that involve the wire bending just aren't indicated for SPE, which is nice because then you're saving your child or that child the 2,000 milligrams of amoxicillin every time. Please be kind to dentists when we're asking you for clearance for procedures, including antibiotic coverage. This is something that is not standardized in our education, and it's not something that we do that often. So I know when like an orthopedic surgeon asks you for clearance, they have these like pre-made beautiful sheets where you just check. Dentists really, a lot of times, don't know what to do. We might just email you and say like, hi, can I have clearance for scaling and root planing? And you might respond, what is scaling and root planing? I'm not certain what's going on. Just call us, let us know what you want. We want to work with you and do a good job and make sure that we're all taking good care of patients. So please be patient with us. So if you have any questions about dental SPE prophylaxis, please email me. So our third objective, discuss the management of pediatric dental trauma. This is one of my favorite topics. So for a practice board question, you see a 15-year-old boy, he's having a sports evaluation and he's a competitive basketball player, and parents want to know if he should use a mouth guard during sports, which is the most accurate statement. So A, basketball has one of the highest rates of dental injuries among high school sports. B, most dental injuries occur in athletes who are wearing a mouth guard at the time of injury. C, the rate of dental injury is higher during sports practice sessions than during competition. D, the risk of dental injury is much lower if the boy uses a professionally fitted rather than a self-fitted mouth guard. Or E, the use of the mouth guard will decrease the boy's risk of sports concussion. So take a moment and think about it as I grab my water. And the answer is A. So why is the answer A? So basketball has one of the highest rates of dental injuries among high school sports. In boys, The highest risk sports are basketball, baseball, wrestling, and soccer. And for girls, it is field hockey, softball, basketball, and lacrosse. And even in athletes participating in non-contact sports such as swimming and track, they're all at risk for dental injury, just like any other injury. And I've seen plenty of swimming injuries from hitting the bottom of the pool. So why is B wrong? Mouth guards decrease the risk of oral injuries, including tooth avulsions, tooth fractures, and lacerations. So most injuries do not occur when you're wearing a mouth guard. In sports that don't require mouth guards, most dental injuries occur in athletes not wearing them. So why is C wrong? So dental injuries being higher during sports practice. So the rate of dental injury is highest during competition. However, athletes spend more time practicing, so you should wear your mouth guard during practice and competition. And D, so the risk of dental injury is lower with professionally fitted versus self-fitted mouth guards. So that's wrong because custom mouth guards may fit better and may be more comfortable, but they don't consistently show to have a decreased injury rate compared to off-the-shelf models. What I usually say about this is that if it's more comfortable, they can breathe easier and they can speak easier, they're probably going to be wearing it. But as far as if they're both wearing it and comparing apples to oranges, both are perfect. Lastly, mouth guards decrease the risk of sports concussion. Unfortunately, this isn't true. Although mouth guards decrease the risk of just dental alveolar injury, they do not prevent concussions. They used to think there was a possibility of that because when your condyle, if it snaps shut and hits where it articulates with your skull, they thought that force could cause concussion. And if you eliminate that by putting a mouth guard in the mouth, it could reduce the risk. But sadly, after a bunch of very tragic studies on monkeys, they found that this is not a contributor to concussion. So I sent a dental trauma guide to your faculty. On the front, there's primary tooth trauma, and on the back, there's permanent tooth trauma. For each type of trauma, it talks about the type of injury, a picture of it, and then the treatment. I've pulled out a couple that I think are more common and more important, and you can just go over them whenever you want. You can laminate it and keep it in case you feel like treating dental injuries at some point in your practice. So a complicated crown fracture in a baby tooth. What that is a chip on the tooth with a pulp or a nerve exposure. So when you look at the cross section that's been chipped off, you see a little red thing. That red thing is the bleeding nerve. So the treatment for that is no emergency treatment is needed, but they should see a dentist within the first 72 hours. Why it's 72 hours is we know that that's how long it takes for the bacteria to crawl into the nerve and then cause irreversible damage. Whereas if it's been less than 72 hours, the bacterial infection is pretty superficial and easier to manage. Dentists will either extract or perform a procedure to save the exposed nerve. I'm going to tell you now, if this happens to your very sweet 18-month-old, typically the best treatment is just to take it out, because in order to do the alternative treatment, it typically would require general anesthesia, which for a baby tooth, usually my thought is not worth it. A lateral luxation, so that's when the tooth is displaced laterally, and the treatment is you don't need to do any sort of emergency treatment unless the tooth is an aspiration risk, or if it's displaced so much that the patient can't close their mouth anymore. If there's a minor interference with the bite, you can just monitor it and watch for spontaneous repositioning. So magically, between the lip pressure and the tongue pressure, a lot of times these teeth will move back to their original home. But if there's severe occlusal interference, so if the patient cannot close their mouth anymore, the dentist will probably either reposition it or extract it. For an avulsion, that's when you completely lose the tooth. And this injury is one of the more likely injuries to cause damage to permanent teeth. The treatment is you don't have to do anything unless you're concerned for where that tooth is. So if you're concerned that the patient could have aspirated the tooth and the legal guardian has no idea where it is, you can consider a chest x-ray to rule out aspiration. With these, you do not put them back in. A lot of parents want to put them back in. They desperately want their perfect little beautiful baby to have its front tooth still. But the most important thing in this situation is to leave the permanent tooth that's forming above it alone and to not reintroduce something that's just been in the outside world and potentially cause an infection in the alveolar bone adjacent to the forming permanent tooth. And usually once you explain that to parents, they're pretty understanding. For post-op instructions for primary tooth trauma is you want to follow up with your dentist as soon as possible. You want to do gentle but thorough oral hygiene in the area. Cleaner teeth heal better than dirty teeth. Soft food diets for 10 days. Ibuprofen is needed for anti-inflammatory and for pain control. And if there's any sort of soft tissue damage, so if there's like a big frenum laceration or a big gum laceration, I'll usually recommend an alcohol-free chlorhexidine rinse for 10 days. And if the child is too young, like younger than 6, and they can't swish and spit, then you can have the parent just dab a Q-tip into the chlorhexidine and then dab it on the teeth. Then you also want to just let the parents know that the tooth may darken. There's always possibility for permanent tooth damage, especially if the child's under 3, because those permanent teeth are still really forming. If the tooth was avulsed or knocked out, or if the tooth was intruded or pushed in. And you want the parents to monitor for signs and symptoms of pulpal necrosis or the nerve dying. And if the nerve does die, extraction is indicated. We don't mess around much with doing root canals on baby teeth. Okay, so let's go over permanent teeth for the trauma guide. So for an extrusion, that's when the tooth is displaced axially or out of the socket. For that, emergency dental treatment is needed. Basically anything with a permanent tooth where it finds itself in a new location that would require or benefit from sooner treatment. So if possible, reposition and have the patient bite down on a washcloth to maintain the appropriate tooth position until the dentist can splint it. So if you find that you want to be brave and you want to try to push the tooth back into its right location, that's great. But what you'll find is as soon as you take your fingers off, most of the time the tooth will drop back down. You have to put something in their mouth like gauze, cotton rolls, a washcloth to have them bite it and hold that tooth in place. When they eventually see their dentist, they will splint it in place and keep that splint there for about 2 weeks for the tooth to heal around it. For an intrusion, so that's displacement of the tooth into the bone, so it gets pushed up. For treatment, what we want to do is the dentist will either monitor, orthodontically reposition, or move it back in the right spot with braces, or depending on the maturity and degree of intrusion, they might actually surgically reposition, which is just a fancy word for putting a forceps on the tooth and pulling it out a little bit. Once intruded, the tooth is repositioned, the dentist will splint it for about 4 weeks. So if it gets pushed in, don't touch it, just send them to the dentist. If it gets knocked so that it's out, but not out all the way, extruded, then you can go ahead and try to push it back in. For avulsion, so that's when the tooth is completely displaced. For this one, this is the only dental injury that requires immediate emergent treatment. So have the parent or the legal guardian put it in as soon as possible. So if you're unable to reimplant, so that could be because the parent's just not willing to do that. I've been on the phone with parents a lot of times and you tell them just, grab it and just put it back in there. And they're like, no, not going to do that. Other reasons why you might not be able to get it back in is if the alveolus or the socket around the tooth is crushed and it just doesn't fit anymore. So if you can't get it back in, you want to put it in cold milk until the healthcare provider can reimplant it, and then dentist will put it back in its spot and splint it for about 2 to 4 weeks. For post-op instructions, they are the exact same as what we say for primary teeth, but if pulpal necrosis or death of the nerve should occur following the injury, a root canal is indicated. So for baby teeth, if the nerve dies, we typically just take it out. If a permanent tooth nerve dies, we don't want to take away people's teeth, especially not their permanent front teeth. That's when we'll do a root canal. So what types of dental trauma require acute management for primary teeth or baby teeth? It's very, very few. Anything that you think is at risk for aspiration. But I will say, even though in all the guidelines it talks about aspiration risk, I've never heard of a child aspirating a tooth that is very, very wiggly. I've heard of aspiration when the tooth has been knocked out, but not if it's just dangling by a thread. Also, if the tooth is displaced to a point that the patient can't close their mouth anymore, that's going to require acute management. And for both, extraction is typically what we'll do. And if there's concern that the tooth was already aspirated. So for that, you want to take a chest x-ray. You can see in this little chest x-ray here, there's a little tooth right there. Or lastly, acute management is required if you're concerned for a traumatic brain injury. And that's something you guys are much better at managing than I am. For permanent teeth, any sort of dental displacement injury. So like I said, if a tooth finds itself in a new location, so luxations, intrusions, extrusions. For those you want to reposition and splint, and timely treatment, moving the tooth back into the spot it came from, is better to preserve the pulp or the nerve and the periodontal ligament cells. The periodontal ligament cells are in the root of the tooth. There's a layer of ligament cells that are alive and help attach the tooth into the bone. These cells are very sensitive, so when the tooth gets moved or displaced, a lot of times they can die, and if you put them back in the right spot sooner, it helps the prognosis. So how do we reposition the teeth? What we want to do is first we will numb. That's a step that you'll probably skip if you want to try this yourself. Then you can reposition it manually with your hand or with a forceps. If you're trying to reposition a tooth, just a reminder, afterwards you need to splint it or do something to keep it in the right spot. Like I said, they like to go back to where they came from as soon as you let go. So a dentist will use something called just a regular splint, which is very similar to braces. I've seen from an emergency department before a emergency room physician use something called Copac as a splint. So that's basically like two different liquids that you mix together in a tube. It makes like a Play-Doh consistency and then becomes very hard, and they smush that against the teeth after they repositioned and let it harden. And that worked perfectly as a splint until I was able to treat them. Or the last one is a good old-fashioned washcloth. So just having them bite on a washcloth to keep that tooth in the right spot. So what types of dental injuries require acute management other than the displacement injuries? So that would be obviously the avulsion. So for that, you want to replant and splint. So how to replant an avulsed tooth? Most ideal is immediate replantation. So if you're ever at your kid's soccer game and the kid knocks their tooth out, like if you can just run up there and put it back in, that's going to be the best thing for that tooth. So what you want to do is hold the tooth by the crown, or the part that you see typically in the mouth, so the part that is covered by the enamel. Remove any gross debris. You obviously don't want to replant it if it's covered in gravel or grass, and then just push it back in. If you cannot replant, which like I said, if the patient's not cooperative, or if the alveolus is crushed, you can put it in a storage media until the dentist can see them. The best ones would be, number one, Hank's balanced salt, but no one really has that during an emergency. Cold milk and spit. Fun fact, people have done lots of studies about alternative storage medias because, you know, in the modern year of 2021, a lot of people don't drink milk anymore. They like to drink almond milk and soy milk, or as my husband says, I always like to order my coffee with the whatever the trendiest, newest milk is out there. So what we find is those work too. The best though is whole cow's milk. And the amount of dry time, or the amount of time the tooth is just out in the world, is a major determinant of the health of the tooth. And all of these teeth, once they're put back in, are probably going to require root canal treatment. Lastly, jaw fractures also require acute management. For this, you can refer to the emergency department, and they're managed by oral surgery, ENT, plastics, whoever takes facial trauma call at your hospital. And lastly, if you have concern for TBI, you want to also manage that acutely. So if you have any questions about trauma, please email me. Fourth objective is become familiar with the effects of prematurity on dental development and with recommendations for non-nutritive sucking. So a 6-month-old infant comes to your office. She's born 28 weeks. Her neonatal course was complicated with prolonged intubation, treatment for necrotizing enterocolitis and sepsis. And since discharge from the NICU, she has been well with appropriate growth, and she's developing appropriately for correct age. Her parents have questions about teething, which is the most accurate. So the infant's likely to have anodontia, or absence of teeth, delayed dental eruption, early dental eruption, hypodontia, or supernumerary teeth. So take a moment to think about that. And the answer is delayed dental eruption. So infants born less than 30 weeks and less than 1,000 grams, they're more likely to have delayed dental eruption. And that makes sense because their corrected age is 3 months younger than their peers. So what is delayed dental eruption? That's when a tooth comes in more than 6 months after the expected eruption time. So there's age and there's also race-related variations in primary tooth eruption. So that includes that girls and African-American children have slightly earlier eruption than their peers, and prematurity and low birth weight are associated with delayed eruption. For non-nutritive sucking, here's a practice boards question. So an 18-month comes to your office. Parents report that she's sucking her thumb and she's done it since 4 months. And they know that she sucks her thumbs throughout the day, but it's more common when she's tired, hungry, or scared. And they ask about ways to get rid of the habit. Best recommendation is to consult the dentist regarding the placement of a habit cessation dental device that will stop encouraging thumb sucking. I'm sorry, that's a typo. Do nothing. Most children will stop sucking their thumbs without any specific interventions. Place gloves or socks on her hands at the times when she's most likely to suck her thumbs. Remind her verbally to stop sucking, or start a sticker chart or other system of positive reinforcement for not engaging in the behavior. The answer is do nothing. Most children will stop sucking their thumbs on their own. So by age 1, about 40% of kids use a passy and 30% suck one of their fingers or their thumbs. But by age 4, the rate has decreased dramatically to about only 4% still use a passy and only 12% use their thumbs or fingers. So benefits of non-nutritive sucking would be self-soothing, and the risks would be irritant dermatitis, herpetic whitlow, and calluses on the associated digits. And children who continue after permanent dentition erupt are at an increased risk for an orthodontic complication. So what does that mean? Non-nutritive sucking, especially if it's prolonged or if it's very intense, can cause changes to the dental alveolar complex that can kind of shape the bones to form around the pacifier around the thumb. So here you have a patient who you can see their back teeth are closed, but their front teeth aren't overlapping at all. This is called an open bite. This is a very common complication with prolonged sucking habits. And obviously, in the ideal world, we want our top teeth and our bottom teeth to overlap because that's considered more aesthetic. And it's also what allows us to incise into things and like tear pizza and lettuce and other foods like that. So for non-nutritive sucking, from the dentist's perspective, what I like to tell parents is that as pediatric dentists, we're only focused on the teeth, only focused on the mouth, probably too much so. So we care a little bit more about non-nutritive sucking than a pediatrician does because we know it can change some things with the bite. So we want them to quit before 36 months, not waiting for it to spontaneously go away in 4 years. And that's because at this point, all the permanent teeth have come in, and the primary teeth position, at this point, all the primary teeth have come in, and the baby teeth position dictates the permanent tooth position. So even though the permanent teeth don't start to come in until about age 6, dental alveolar changes from non-nutritive sucking can cause malocclusions if they're not stopped before 36 months. So some habit cessation strategies include, for the thumb, you have to wait until your child understands why it's important to stop. So that's not until at least after 2. And for the passy, it's easier to stop it before potty training than to tackle potty training and passy cessation at once. So for that, we recommend a lot of times going cold turkey or successively cutting the nipple away of the pacifier. So dentists will place habit cessation appliances when multiple permanent front teeth have come into the inappropriate location, other methods have not worked, and the child wants to quit the habit. So the child has to want help to stop the habit. If the child really doesn't want to stop the habit, it feels like torture to have something like in this image put in your mouth. So if you have any questions about non-nutritive sucking or prematurity, please email me. I think this is our second to last objective. So review tooth loss and space management. I think this is a little bit esoteric for pediatricians, but it's something that I was requested to review. So I'm happy to go over it, show you some of the cool devices we have. So causes of early tooth loss would be trauma and cavities. So the tooth was treated by having to take it out. So this tooth got a cavity, the cavity turned into an abscess, the tooth needed to come out. Why do we care about early tooth loss of baby teeth? The adjacent teeth will shift to fill the open space, and this can cause crowding or impaction or inability of that permanent tooth to come in the right spot. So for tooth loss and space management, if we lose this baby tooth here, what will happen is the tooth behind it will shift forward, the tooth in front of it will shift back, and the tooth above it will shift down. So it creates a whole mess. So some space management strategies for anterior teeth. The front 4 teeth that you can see here, top 4, bottom 4. You actually don't need space maintenance because the teeth will not shift into the space of the front teeth. For posterior teeth or back teeth, so the molars and the canines, you should get space maintenance. And that's indicated if the permanent tooth is greater than 6 months away. And the types include a whole bunch of different creative ones. So we have band and loop, so that's when there's a band around the tooth behind, and a loop that reaches out and touches the tooth in front, and it helps hold the space until that permanent tooth can come in. A distal shoe, that's a modification of a band and loop and helps with if one of the permanent teeth is not in. There's a lower lingual holding arch, so that's for if you're missing multiple teeth on the bottom on both sides. And then a nance, that's similar to a lower lingual holding arch, so that's when you're missing multiple teeth on the top on both sides. So you want to put these space maintainers in as soon as the tooth is lost. So most space loss occurs within 6 weeks and 6 months. So if it's been already more than 6 months, a lot of times a space maintainer really isn't going to help you much. And you want to remove it once the permanent tooth is visible through the gums. Some complications with space maintainers include they can become displaced or dislodged into the gingiva and cause irritation. They can be plaque traps, so they really require brushing really well. They can deflect a permanent tooth if they're kept in place when that permanent tooth is erupting. So if you can imagine like that little loop from the band and loop, if that stays there and the permanent tooth is continuing to come in, it can get stuck on that. So for all these reasons, if they get a space maintainer, they really need to be followed by a dentist. If you have any questions on space maintenance, just email me. And the last one, woohoo! So pediatric dental clinical pearls, simple ways to implement oral health guidelines in your pediatric practice. So how to do an exam. Some tips for that. I really like the knee to knee. So this would be you sitting with parents facing knee to knee. You can do it just in your lap, or you can get a stay in place lap cushion, or I like to call it like a little surfboard. What you do is have the parents give their child a bear hug and then lean their child into your lap and hold their hands and feet while you do the exam and you manage the head. If it's on the exam table, just standing towards the end of the exam table. To help keep their mouth open, you can use the snap position. So this is where you take your index finger and you put it up inside the mouth in the maxillary process, and then you put the thumb in the lower vestibule, so in here, and you push down. It's very similar to when you intubate someone, that same motion that you use. What you find is that when you press down in the lower vestibule, so not extraorally, but in here, it's uncomfortable and most people will open in response to that pressure. You can also use something called a mouth prop. That is something that will hold the mouth open. There's professional dental mouth props, and the other one is a good old-fashioned rubber door stopper. That works. You can put it in the dishwasher or in the sterilizer, and it's safe for them to chew on without harming their teeth. So a lot of times the parents talk about, my child like really will not open at all when I try to brush their teeth. Usually one of my first suggestions is try a rubber door stopper, put it through the dishwasher afterwards, and see if it helps you. So how to apply fluoride varnish. We're seeing more and more pediatricians applying fluoride, which is great, especially for the really young ones because a lot of them don't have dental homes yet. So you want to put it on children that have a risk for cavities. I'll give you a little handout, but what you'll find is it's pretty much everyone. What you want to do is dry the teeth beforehand with a little bit of gauze, and then apply a very thin layer. What provides the protection from the cavities is the concentration of the varnish itself. It's not how many layers you paint on the teeth. So I very rarely use the entire amount. So if you have a little 18-month-old and they have 4 teeth, you do not need to use that whole container, just a little bit. For post-op instructions, everyone is different, with their brands. So just review the manufacturer recommendations. There's usually instructions on when the child can resume eating and drinking and when the child can resume brushing. Another great resource for you guys is the Baby Oral Health Program, or BOP website. This is the website link. It has a lot of stuff on there for pediatric patients and for providers. And it also has a caregiver presentation that you can go through. And it has some provider training videos. So how can you help us? How can you help the pediatric dentists of the world? I'm sure a question you ask yourself every day. So you can counsel patients on oral health. So you can go over oral hygiene instructions, dietary recommendations. So I know we have very consistent messaging on avoiding juice now, and fluoride recommendations. So our fluoride recommendations, our new ones, are actually brushing with fluoridated toothpaste from the very first tooth. Old guidelines said wait until age 3. You want to use just a grain of rice on ages 1 and 2. That's totally safe for them to swallow. And then starting at age 3, they can graduate to a pea-sized amount. You also can screen for obvious oral pathology and refer. We like to see them for a year 1 dental visit. So see them before they turn 2 or within 6 months of getting their first tooth. And then how can we help you? So we can screen for GERD, obstructive sleep apnea, eating disorders, substance abuse. These things all show signs in the oral cavity before, these things all show signs in the oral cavity. So we can see if a child has GERD based on the way that their enamel is eroding. We can also counsel for the HPV vaccine, since there is indication that HPV vaccine is preventative from oral pharyngeal cancers. And if anyone wants to collaborate on any of those things, just please let me know. I'd be happy to talk to you about it. So that is it. Please, like I said, email me with any questions. It is kellymlipp@gmail.com, and I hope you guys have a great rest of the day.